Here, and the patients looked at very carefully, and of course, preventing infections, managing the diabetes, ensuring the safety, fall prevention, looking at the limb, and especially which has the access, and making sure they're not I put it together for you. I don't expect you to go through the entire timetable today, but all
in Hershey Medical Center. He received his medical degree from King Edward and has been practicing nephrology for 11 to 15 years. Dr. Umar, please.
थैंक यू. क्लिकर अगर मुझे दे दें, और वो जो दूसरी, हाँ ये जो इसको स्टार्ट कर दें, इसको इनेबल कंटेंट कर दें पीछे जाके. सर अगर आपकी इजाज़त हो तो मैं उधर खड़ा होकर बात कर सकता हूँ. थैंक यू. अस्सलाम वालेकुम. मेरी टॉक जो है ना थोड़ी सी फन टॉक है. I am passionate about it. I have my personal reasons. I'm sure all of us has a passion that why we joined nephrology. So I will be talking about these futuristic devices. हम में से कितने लोग होपफुल हैं कि इनका कुछ बन जाएगा, और कितने लोग कहते हैं कि यार ये तो सब जो है ना ड्रामेबाजी है, इसका कुछ नहीं बनना. कितने लोग अनडिसाइडेड हैं. In 1969, Gordon and Maxwell, so they kind of gave this idea of portable dialysis. So on one hand, you see this dog with the experiment, so you can see the hemodialyzer in the center. So there is arterial output, blood pump, dialysis, and venous return, the blood circuit. But there was also this dialysis circuit, so the water which was there was reused. What do we do with in the dialysis unit with our waters? Liters of water, gallons of fluid with each treatment is just wasted. So they use this zirconium and some sort of sorbent technology to reuse the water. So instead of kind of wasting the water is reused again and again. So the blood circuit is going on, and dialysis circuit is going on as well, but the water is reused. So again, this concept was there, but I don't think it took a lot of popularity. So the idea was there in some sort of experiment, but died. But Dr. Kolff, he experimented this machine and reported its use. He was a genius innovator in the nephrology world. Also, he invented the first artificial heart and membrane oxygenator. So kind of the membrane oxygenator used in ECMO devices and cardiac bypass. So those were some of his inventions. I think he's wearing one of his device he invented Um, he described his experience
So
as
those were some of his
dialysis in
inventions.
Wonderland.
I think
So
he's
some of
wearing one of his
the
device he
wearable
invented.
dialysis, I
Um,
couldn't find a picture
he
of it, but
described
it was like a 3.5
his
kilogram
experience
machine
so
as
those were some of
dialysis
his
in
inventions.
Wonderland.
I think he's
Some of
wearing
this
one of his
machine
device he
traveled wearable
invented.
dialysis. I couldn't
Colorado
find a
River.
picture
He
of it, and then they were
described
dialyzing
was like a
themselves in the
3.5
kilogram machine,
and then
as
they can do
dialysis in fishing
Wonderland.
somewhere, and then they dialyze them in the morning. So the concept of home dialysis was there, but again, I think it took very long before we could, achieve the portability of dialysis. So he thought this was an excellent program to rehab those renal patients who, despite of kidney problems, they could still enjoy the life. So what were the challenges to develop these portable dialysis, right? We do have now portability in the form of PD and home hemo, but still bulky, large fluids are needed, even with the PD, patients can take their machine when they fly from, like one of my patients is flying to Italy, and he can either take his machine or he can take his fluids. So fluid will be shipped by FedEx wherever they go, but they typically take their machine. And then problem with the clotting, long-term access, and really the biotechnology, like technology that we can efficaciously use. So sorbents, which was used in the past and now are coming back again to form some of these devices. So what are these sorbents? So these sorbents are like a series of zirconium and some other substances which actually can bind to something you want to get rid of, exchange it with something which is inbuilt there, saturate the dialysate, take the dialysate, which is saturated, kind of cleanse it, refresh it, and put it back. So there is a urease layer which split the urea, which is one of the uremic toxin, into the ammonia and the carbon dioxide. The gas can be de-aired through the chamber, but the ammonia becomes ammonium and proton is added. So there was some mechanism to really replenish and refresh this used fluid. So what are the different futuristic options, right? So these are on PD side, hemodialysis side, and something like bioartificial or biological things which can be implanted. How many of your patients have asked you about that box that can be implanted like a kidney transplant? Patients, Dr. Salman told me yesterday, like every patient knows about that box, right? So, and then some of my patients asked me, can I be the test subject for the box? I said, no, they are just doing animal trials right now. So these were some of the early PD devices, right? So the first was this idea with Vicenza variable artificial kidney called VVAC, and this AVOC, which is automated variable artificial kidney. So the first one, it uses a double lumen PD catheter. I wish, so there is no light here, but that's fine. So there is in dialysis outflow and inflow line. There are 4 miniature rotary pumps, as you could see. A small amount of fluid can go through PD cavity, come back, the fluid gets kind of regenerated. But this was not used because it's still experimental. There were some problems with this. The electrolyte changes and ultrafiltration control was not there. So those are some of the challenges. Patients who are anuric, they cannot make any urine, so they need some of those devices. So they suggested maybe we can do this during the daytime and use one of the PD exchange at the nighttime because catheter is still there. So the device which is going through more testing, and this is AVOC system. So this system it's PD based. It can use double lumen catheter or 2 single lumen catheters. What you do is you put 1 to 1.5 liter of dialysate in the belly as the base fluid, so it starts its work, and then use 500 ml of fresh dialysate and recirculate in a tidal manner. So 500 is kind of recirculated again and again. And then there is some ultrafiltrate generated, which can be in a different bag. It's battery operated, battery life is 18 hours. So you can see there is kind of a durable or a fixed module on the right side in the top picture. And then the fluid goes through storage, then through sorbent. Then they add the bicarbonate and some of the glucose back into it, and it goes back into the belly cavity. So the whole thing continues. So it has two major components. One is a daily cartridge. So maybe after 7 to 8 hours you have to replace that. So they called it originally daily, but now they're saying that you need more than once a day cartridge. And there is a monthly replaceable assembly. So ammonia sensor, some of the things which monitor the sorbents. Thank you. So the first study was done on 20 male patients using this technology. So there were 4 to 24 hours, and it showed safety, efficacy, and the urea clearance was 31. So because this machine runs round the clock, so you can still get decent clearance from this AVOC technology, and the weight is only 3 kilos. So you can imagine patient can wear this as a jacket and can walk with this. The hemo devices. So this is the picture. I think this is one of the scientists. I believe his name is Dr. Victor Gura on the bottom. He experimented this wearable hemo devices. So this is called WAC. It needs 2 batteries. They use 375 ml of dialysate. The blood volume is 65 ml. So again, its weight is 5 kilos, sorry. So you can say this is also worn as a jacket. So it has a double channel pulsatile counterface flow, and I'll show you a picture as how it works. Again, it has sorbent-based gas, and the plastic is permeable, so whatever gas is generated, it can leak out. There is daily exchange, blood access is needed, and anticoagulation is required. So this is the scheme. So this is the dialyzer or the filter, right? So blood comes through, gets dialyzed, go back. This is the dialysate. So dialysate kind of goes through these cartridges or these sorbent-based pumps and units, and then once the dialysate is clean, when it comes back, the bicarbonate is added, some of the electrolytes is added, so it can be regenerated to do its job again and again. So inside the filter, so this is what they do. This is kind of a push and pull. So this whole cycle, so if the increased pressure in the blood chamber, there is decreased pressure in the dialysate chamber. So this is how the pressure is created across the membrane, push, pull, push, pull. And this led to, the blood flow was only 100 and sometimes less. So because you don't want to have a very high blood flow on this either, but it was still very efficacious because of this pump. So this was the first trial. This was published in Lancet back in 2007. So there were 8 patients from UK, session 4 to 8 hours, blood flow 58, dialysate 47, and urea clearance was 22 ml per minute, and creatinine clearance was 20. So there was no major cardiovascular issues, hemodynamic issues, or hemolysis issues with this, the first kind of reported version. So then FDA allowed some of these drugs through the kidney accelerator program to do fast trials. So the trial was done in 2014, and this is what happened with this trial. They published, I think a couple of years ago. So 7 patients, this was 24-hour treatment. So blood flow at 42, dialysate 43. There was urea clearance, creatinine clearance 16, 17, phosphorus and beta-2 microglobulin. So it was effective or efficacious, but this is what happened. One patient, treatment was disconnected due to clotting after 4 hours. The other, treatment was stopped because of discoloration of dialysate, so something happened inside the filter, the blood got mixed. Trial was stopped after 7th subject due to device-related malfunction. So they are trying to redo the design and see if they can improve some of the issues with this machine, so the redesign, and I haven't seen another trial going on this one. So moving to this bioartificial kidney, and I think we have, a lot of us have seen this RAD devices. So what essentially these devices did, and there was a trial about that, is back in 90s, so the RAD had conventional hemofilter lined with monolayer of renal cells. So two filters attached to each other in series, a CRRT filter, which is the glomerulus, and a RAD filter which had renal tubular cells lined. So this was kind of a mimicry of the natural, there's glomerulus, there's tubules. So this was the glomerulus, this did the tubular function. And because the biology was there, so these cells had immune function and also the hormonal and endocrine function. So this led to this phase 2, their trial, 58 patients. 40 had this RAD device, 18 CRRT alone, and they showed some survival benefit. And they believed the benefit was because of the biological functions from the cells which were attached to the RAD. So another fun experiment which I would like to show you. So this was, they took the rat kidney and they decellularized these kidneys by passing a detergent through it. So renal artery, renal vein, this is ureter. So they injected this STS thing, which is just simply a detergent. It washed out all these cells, but the scaffolding or the linings, kind of a building with a gray structure only. And then they infused cells, so cell recellularization. So endothelium from the artery, epithelium from the ureter, took this kidney out, re-implanted in another experimental animal, and did some testing. You know what? There was rudimentary urine. So this kidney, which cells were removed, now cells were added, kind of similar to stem cell concept, re-implanted in a mouse. When the clamp was opened, just like a transplant, there was rudimentary urine which had higher concentration of both urea and creatinine. So this led to some of these experimental things. A lot of things are happening simultaneously. So people are coming to this implantable artificial kidney. So there is this project going on with the Vanderbilt. I'm not sure if I can play the video because I was told the internet is not there. But you might have seen videos on YouTube already about how these implantable, there are a couple of people working. One is in Vanderbilt, one is in UCSF. So they have this coffee cup size device which can be implanted similar to a transplant. So you can see the kind of the arterial connection, the venous connection, and there is a ureter as well. So I think another cartoon, you can see they prefer the right iliac fossa in this picture just to mimic the transplant. So the whole concept is this IAK is going to work on the blood pressure. It does not need a battery. It does not need any other pumps. So it will work on it's a hemodynamic device. And there are challenges too as how to develop that things which is durable, it is efficacious, and it works long term. So two concepts. One is this hemo cartridge combined with the bio cartridge. So this bio cartridge has cells, as I mentioned in the previous experiment, glomerulus and the tubule. So they use this silicon nanotechnology, which has a specific 7 nanometer pore size, similar to, again, creating a structure similar to slit diaphragms, and it's the size barrier. So, albumin and larger particles stay behind. Potassium, sodium, other stuff, smaller stuff, they can be filtered. And this is the bioreactor, which is in the bio cartridge. Again, a similar concept. They use the same technology and add kidney cells, the kidney tubular cells to it. So there is glomerulus function and there is a tubular function. So anything that gets filtered, these tubules are supposed to do the function of the reabsorption in this bioreactor or bio cartridge. They expect that the patient may end up making 2 to 4 liters of urine, so how to manage? Patient has to weigh themselves every day and drink more water. So one of the comparison, and this is, I'm going towards last couple of slides, is, in summary, so the AVOC, which is the PD-based device, lightweight, battery-operated, currently in the human trials, is bloodless, portable, but then limitation is you have to change a cartridge very frequently. The WAAK I showed you, it's again battery operated, needs some fluid. It's going through FDA clinical trials. First trial was stopped, more trials are being designed. But ultrafiltration is low with this, and clotting and bleeding issues are a problem. And basically you cannot use like a fistula for a very long period of dialysis with these devices. The implantable, again, you don't need any battery power. It's lightweight. Patient has to drink water and electrolytes. Still in the animal models, we are still probably a decade behind maybe when this will be used. They think it's closer, but we have yet to see. It's implantable, and then we don't know how long it's going to work. A kidney may work, several number of years, but we don't know how long this is going to work. And they haven't really explained when like this bioreactor will be connected. I think we yet to see more data. So what our patients really need, there are devices coming, there is artificial intelligence, there's machine learning, there are a lot of things happening simultaneously. So not only our patients need some of these, fancy devices, but really a system, a feedback system. Like we have, human body is a great creation. Allah Ta'ala ne, jab bhi physiology mein padhta hu, I always get impressed. So we don't need like machines and all of that. So biological system has feedback loops and ability to give feedback. So we need these biosensors, devices, maybe some smart t-shirts, smart watches. And then if there are changes happening in the patient's fluid status, blood pressure, the machine has to give feedback to the dialyzer or your kidney in the box, which is implantable. Hey, slow down, go faster. So I think there is still more time and more technology has to emerge. These people have to go through, not only the innovative problems and issues, but they have to deal with the FDA approval and some of the other challenges. So it's not like what happened to Apple. There was an innovative genius who's Steve Jobs. He combined with the business genius Tim Cook. So they took the Apple to the next level. Now the innovation is kind of gone down. It's only the business. So they keep refurbishing. So we need to have innovative people combining with the business people. So that's the only way I think these devices will get a large global presence. So last slide. So this is how we started. Some of these machines we currently use to these new PD-based devices, hemo-based devices, and the implantable devices. Thank you.
Thank you so much for your talk. Just in terms of this clinical trials, so device trials, not having sham devices, what kind of study designs are they employing for this kind of work?
Yeah, no, you're right. So it's kind of difficult to have a randomized controlled trial. How are you going to have a sham device if there's one PD device? I mean, you can, so that's one of their problem as well. And I think that's why the ASN is partnering with some of these. So you might have heard the Kidney X, the accelerator project. So they are going through this FDA fast track approval and avoiding some of these, the historical methodology, because people feel that there is need for these devices and somebody has to go, and some of those things are kind of not overlooked but bypassed because of these innovative or accelerator pathways. Please.
2009, when I was working in US for one of the R&D companies for medical devices for kidney, the state of this artificial from University of Southern California was still the same in 2009. In 2019, how far they are, and when you think they will be on first human?
So you're right. I think I have been following this, the development for many, many years. So I gave this talk back in 2013, and trust me, when I looked the literature, so there are some things. The new thing is clinical trials. So human trials for the PD-based device, selection. There is not just one company. There are companies in Holland, Australia, New Zealand, Canada, which are working on these. But selection of one or two through this accelerator pathway to go through human trials. And I think that's an advancement in the PD-based and in the hemo-based device. But the advancement in the implantable, I think we will see. I mean, they've done some animal trials. I think they put in a dog and it worked for 30 days, but this was not the bio cartridge, just the first part, just the filtration part. And there was like no fibrin, and they were able to make it work.
Thanks, Dr. Umar Farooq. We'll move to the next speaker.
Thank you.
Okay, the next speaker today is Professor Mary Richards. We've heard her yesterday. Professor Richards has over 30 years of experience. She has worked in the UK, Australia, Africa, Middle East. Clinical genetics, sorry. She has worked in the Middle East, and where she launched a master's program in renal nursing in collaboration with the De Montfort University in the UK. Mary is an active member of the ISN. Her topic today is a nurse-led vascular access program improves outcome.
Thank you very much for the introduction, and thank you for the opportunity to come and speak and join in this fabulous conference. And good afternoon, everybody, or good morning, everybody. Following on to encourage organizations to work more with nursing and develop nurse-led services. And if we're looking to build capacity for kidney disease, we certainly need to have more collaborative and multidisciplinary working. And I mentioned in my talk yesterday a couple of initiatives that we had. So looking back at the historic problems within Abu Dhabi, I started working there in 2012. At that time, the true incidence and prevalence of end-stage kidney disease and CKD were not known, and it's only really through the work that has been done over the past 8 years that that has been defined. The take-on rate to dialysis now is around 130 to 150 new patients per million population per annum. The prevalence is around 400 per million on dialysis, and the growth rate is around 6 to 8% per annum. That's compared with about 3% in Western Europe and the USA. The dialysis population there is predicted to double in the next 5 to 7 years. 95% of the patients back in 2012 were presenting to dialysis as an emergency, and that was compared with 30% in Western Europe. We all know, and we've heard many presentations over the course of the conference, that in terms of vascular access, that catheters incur higher cost, higher mortality, very poor rehabilitation, and no chance for prevention or intervention. And at that time as well, only 2% of the patients in Abu Dhabi had an AV fistula at first dialysis. If we look at the benchmarks for dialysis prevalence in OECD, ignore the red lines because that's not Abu Dhabi, which is what I'm hoping to show you, which is actually here. So you can see within that in 2009, Abu Dhabi was around 30 per 100,000, and in 2013, further down here, let me find it, is around 36 100,000. The bottom line is what's really important, and this line is for the Emirati population. So the Emirati population within Abu Dhabi is only around 15%, and you can see here that we're looking at rates of 100,000. If we compare vascular access international patterns going back into 2012 when this first started, you can see here that within Europe and Japan, very high levels of fistulas within their patient populations. The USA had permanent access, but a high number of AV grafts. And here in Abu Dhabi, you could see here, we had less than 50% of fistulae and a very high number of half the number of catheters. Another comparison just to show you. So again here, Abu Dhabi coming in here at this level, 50%, compared with, say, a country like Serbia, where they're running around 90 or 95%. If you look at admission rates, inpatient days and mortality in terms of comparing fistulas and catheters, this is some UK data. And you can see on this that admissions due to access, if you have a catheter, it's around 2.5 times your likelihood to have an admission due to access. You're 10 times more likely if you have a catheter to be admitted due to sepsis. You'll have 2.5 times the amount of days in hospital due to access, and 13 times the number of days due to sepsis if you have a catheter. And the mortality risk is around double. Within Abu Dhabi, it was calculated that the minimum excess cost of having permanent lines resulted in around $7 million a year. Looking at the prevalence of CKD in Abu Dhabi, if you have a look across all stages of CKD 2 to 5, in the 3 to 5 group, you can see that within the national population, it's around 4.5% and very similar within the expatriate population. But the interesting line to look at here is in CKD 2, where you can see that within the national population, the Emirati population, in terms of CKD2 is running around 20% for nationals and a similar number for expatriates. So this is basically a tsunami of CKD on the horizon. It's even more important because if you look at the age of the population of Abu Dhabi, 85% of the population are under 40 years old. So, and a similar situation in the expatriates. So the CKD is going to increase. And then if you look at Abu Dhabi age and CKD prevalence as a percentage, and this is compared with UK data, and you can see also that in every single age group, it is higher within Abu Dhabi. So our solutions proposed to try and address some of these issues, the first one was around an early detection program for CKD, and that commenced in 2014 and started off with a partnership between secondary and primary care. And within the primary care clinics, automated EGFR reporting was implemented and allowing automated detection of CKD. We implemented an algorithm-based management system and an online physician support system. And then we put community nurses out into the primary care clinics, acting as navigators and educators. So these nurses were absolutely essential to identify patients with or at risk of CKD. And alongside that, multidisciplinary teams and were set up, and pre-dialysis clinics were set up in the clinics. Something's not happening here. There we go. In terms of the vascular access service, historically that was a bit of a disaster with no real unifying service. So we developed the vascular access service in 2013 and appointed a vascular access nurse specialist to lead this project. We implemented a nurse-led clinical pathway with nurse referral to the clinics. And this was quite a big change within Abu Dhabi, because nurses were at that time not able to make direct referrals of their own. Referrals could only be made by nephrologists. So to change this was quite a big challenge, but it was considered that the nurses were completely the experts in being able to identify complications and with patients and fistulas. We set up nurse-led vascular surgical clinics in every unit and introduced a routine monthly surveillance program, which was run by the nurses using transonic. The nurses also undertook catheter removal actually in the dialysis clinics, which had not been done before. So that had meant patients going off to the hospital to have those removed. And so now we were removing them in the OPD. It was also important because previously, even if patients had had a fistula created, quite often it wasn't unusual to see patients months later still with a catheter in situ. So this was a big clinical improvement. And the focus of this was on both prevalent and incident patients. So this is what the adopted model looked like. So we've got, find my stick again. See the timely access creation. Following clinical pathway, I'll show you that in a second. The pre-dialysis multidisciplinary team clinics, access clinics and nurses in each of those clinics, trying to push on fistula first, a surveillance program, and the direct nurse referral. This is the pathway that was used, and obviously it's a bit too busy for you to go into every part of it, but just to show the entry points of that into our vascular access nurse service. So this is our nurse, and though she can have referrals coming in from pre-dialysis, from primary care, from inpatient units, or any other unplanned emergency. And all of those go through her, and she will be the one who will coordinate getting the patient safely through to the right access. The impact has been quite incredible. And you can see here, so back in 2012, and you can see that here we've gone from under 400 fistulae up here to over 800, bearing in mind the patient program has increased from patients in 2012, around 450 patients, to around 1,200 patients today. This is the number of lines in the red line, and the green line is our number of catheter infections. So you can see an overall improvement in all three of those parameters. Our vascular outpatient activity changed considerably. So here back in 2012, going from around 400 procedures up in 2016 to around 1,800 procedures. And also vascular access procedures here in 2013 from 100 up to 300 in 2016. Our fistula at first dialysis also improved significantly. So you'll remember I said to you down here, less than 2% back in 2012 when we first started the program, and in 2018 we were around 25%. So a significant improvement in fistula first. We know within the USA that a patient starting dialysis with a line incurs around a $30,000 additional cost in the first year. So for us in Abu Dhabi, between 2015 and 2018, this equates to a $9 million cost saving, which I think is significant. I spoke a little bit yesterday about our Masters in Renal Nursing program that our nurses are encouraged to go through to improve their expertise, to be able to lead the development of services. And this was a small study, observational study, done by one of our students last year. looking and following up patients in terms of fistula first in Abu Dhabi. From 2015, followed up for 1 year. So if you have a look at this, you can see that in the fistula first group and the non-fistula first group, there was not much difference in terms of males, around 65%. In the fistula first group, of Emiratis, about 18% in the fistula first group, and about 32% in the non-fistula first group. In terms of follow-up was around the same, around 340 days. Loss to follow-up was higher in the non-fistula first group at 26% compared with 10%. There were more diabetics in the fistula first group, 71% compared to 57%, and the mean age was higher in the fistula first group. If we look at the outcomes here, you can see that for the admission all causes, there was a higher number of admissions in the non-fistula first group, 78% compared with 51%. There were more access-related admissions in the non-fistula first group, 61% compared with 24%. There were more admissions due to sepsis in the non-fistula first group, 29%, 30%, compared with 8%. And there were more interventional radiology interventions in the non-fistula first group, 34% to 8%. We had 1 death in the fistula first group and 15 deaths in the non-fistula first group. And this was all in the first year. So going back to the vascular access patterns, and if we looked at 2012 and include now 2018, you can see here we've still got Europe and Japan with high numbers of AV fistulae in their programs. The USA has gone from 2012 having and now moved to 2018, having more AV fistulae and less AV grafts. And here in Abu Dhabi, you can see here we've gone from having more AV fistulae and less catheters. So in conclusion, within this part of the world, the prevalence of CKD 2 to 5 is very high considering the age of the population. End-stage kidney disease prevalence is low compared to international comparisons. The incident rates for dialysis are high, and the growth rate of the dialysis population is also high. The dialysis population is predicted to double in the next 5 to 7 years. Early detection of CKD has reduced late presentation from 90% to 30%, and fistula first has increased from 2% to greater than 25%. We can see that fistula first clearly improves patient outcomes. 80% of our prevalent patients now have an AVF, AVG, which approximates to international norms, and quality outcomes have improved at reduced cost, and this is an example of value-based healthcare. And the demand for this service will continue to rise. In conclusion, service development and improvement is essential to build capacity, but to do that, a multidisciplinary approach is essential. It's really important to include all locations where renal patients are seen. That's not just in your dialysis clinics, and this is where nurses can have a huge contribution to make within the care of patients and in terms of making sure that they can go out and work remotely in other areas. Nurses deliver the care. They are the experts and should be included. Nephrologists must recognize and champion the development of nurse-led services if we want to build capacity. And nurses must be involved in all aspects of the process, from policy, quality standards, care delivery, and evaluation through data collection and audit. So I would like to ask you, do your nurses have a seat at the table of decision-making in terms of service developments within your organizations? Thank you very much.
We have time for questions. Please go ahead.
have a lot of nurses on the table with me when we develop these policies. So my question is about the surveillance. So did you add the surveillance piece to it if the nurses had a protocol to do surveillance for these fistulae every 6 months, once a year, or not?
Yes.
You do.
Yes. So as part of the whole change in the service development from the moment of introducing the vascular access nurse specialist and her team, a protocol for vascular access service was implemented, and that was in all of the clinics using the transonic. Clearly, in each clinic, there's only one vascular access nurse. So other nurses have to be trained in terms of how to use the transonic equipment and make sure that the patients get the regular surveillance. Because that's absolutely critical, because getting the fistula in is fantastic, but actually taking good care of it and identifying problems in a timely manner is arguably more important. So it's all part of the same process.
Dr. Kadri, please.
Thank you so much for this extremely pragmatic approach, and which actually works. But in a country like Pakistan, we still haven't had advanced nurse practitioner models take up, so there are regulatory issues, there are conflict groups. Our own medical fraternity is, sometimes responsible for not facilitating that. So how would you suggest our nurses in our dialysis setup take up a lead role when they cannot serve as nurse practitioners?
Okay, so firstly, I would always ignore things like titles of advanced nurse practitioners, clinical nurse specialists. There are many countries in the world that don't have those yet, don't have the regulation for them. And Abu Dhabi was a case in point. There was no set job description or PQR for that type of role. But I think if you wait for that to happen, you're going to wait a long time. So I don't think there's any reason why you can't develop these services and have these people. It's going to happen. You will get that regulation within time, but you don't have to wait for a title to enable a nurse to help support a service to build capacity. So I think so long as those nurses have the right level of education and expertise and the right support from the nephrologists, then you will have a successful service. So I wouldn't get hung up over titles. I would just say a vascular access nurse specialist can be any nurse in your clinic.
Last question by Dr. Irfan.
Thank you, madam, for the lovely talk. And I would like to make a comment, and even on what Sir Kadri said. At King Edward Medical University, we have started a allied health program, and in that we have renal dialysis technologists. So these are, you can say, they are specialized renal nurses, and they do a 4-year program in renal dialysis. So that is completely dedicated renal dialysis technologists, and they study transplant, they study dialysis, they study CRRT techniques, and they study peritoneal dialysis as well. And all those students, they, after doing their FSc in pre-medical, they join us, and after that 4 years training, they are doing a marvelous job. And there are many colleagues, Dr. Abira is also sitting here, Dr. Zahid Rafiq at FMH, and in all 3 or 4 centers which I am looking after, they are charity centers, and in all of those centers, the specialized renal nurses, they are taking care of that all, and we have found very good results. So I completely agree with you on this, and we have to work on it, because what I have seen in our practice, that all of our seniors, our professors, nephrologists, most of the time they can't, because of their busy schedules, they can't sit in the dialysis center, and they cannot spend their whole time with those dialysis patients. But these patients really, they need someone who is skilled enough to look after them and to identify their problems beforehand. Otherwise, most of the time what happens when we have non-technical people looking after these patients, some people who has done his 6-month training as a dialysis technician, or a person who is just matric passed, and you know that a high school education, they are not adequately trained, and they do not have the basic knowledge about those things. So I would say that all of us should promote this renal dialysis technology, and if even other centers, they can start that 4-year program. And I would also request my seniors that we can also take it, because yesterday I was seeing your slides of MSc in that. We are still at the BSc level, and I was seeing the curriculum in India that they were doing that MSc in those. So we can, even after that basic education of 4 years, we can introduce super specialization for them, as you have mentioned that someone of them can be further trained in vascular access. And we have an infrastructure, we have centers which are making AVFs, we have centers which are doing peritoneal dialysis. Unless and until we train our nurses in those roles, we won't be able to lead such successful programs.
Can I just say also, I mean, the MSc is one thing, but many of our nurses working in vascular access don't actually have the MSc, but we have people working and supporting them with that level of education. But I spent yesterday lunchtime with a lot of the nurses here from Pakistan, and we had a lot of discussion around things that they would like. And most of them are really, really motivated to get involved in things like vascular access programs. You know, again, you don't have to wait to have things like master's programs to do this. You just need to have a program of education and support and training.
Thank you, Professor Richards. The next talk is on intradialytic hypotension, and the speaker doesn't need any introduction. Our respected Professor Tahir Shafi, former Dean of
Thank you, Chair. Well, ladies and gentlemen, it is my great pleasure to give this talk on intradialytic hypertension, which has been always a challenge for the nephrologists. Okay? Although many new technologies have been developed with the better insight into the pathogenesis, and that is the pathogenesis of intradialytic hypertension, but still long-term placebo-controlled randomized trials are needed or awaited to show their effectiveness in preventing the intradialytic hypertension and improve the outcome. I was supposed to talk about the treatment and prevention of intradialytic hypertension. I will start with the definition, and then pathophysiology, then we'll come to the treatment and the interventions to prevent the hypertension. There is not a single uniformly accepted definition of intradialytic hypertension. During the past 2 decades, more than 24 definitions have been used by different investigators and the guidelines. And most of these definitions include 3 components. That was the measure of the intradialytic blood pressure behavior, intradialytic blood pressure decline, absolute or relative, and or occurrence of lower blood pressure during dialysis at or below a specific threshold. And secondly, intradialytic symptoms, which were related to the hypertension, light abdominal discomfort, nausea, vomiting, dizziness, fainting, restlessness, anxiety, yawning or sighing, and finally the requirement of the intervention to correct the hypertension. 2 more popular definitions. One was the KDOQI guidelines, 2005. They said decrease in systolic blood pressure by 20 millimeters or more, or decrease in mean arterial pressure more than 10 millimeters of mercury with symptoms. And the European best practice guidelines in 2007 have the same numbers and presence of symptoms, but they added the requirement of interventions. Lately, in 2014 and 2015, these investigators emphasized more on the blood pressure numbers with the assumption that while analyzing the retrospective data, the information about the symptoms and the intervention is more often absent or not available. So they talked about the systolic blood pressure drop more than 30 to a level of less than 90, and the other definition was systolic blood pressure fall equal to or more than 35 during dialysis, or in any intradialytic systolic blood pressure less than 90 millimeters of mercury.
Centers,
They
can
ignored
start that
these
4-year
symptoms
program.
and the interventions.
7 years. 9
Then the
58
pathophysiology,
40 had
the
this random.
multifactorial. Large number of complex interrelated factors play a role in causing the intradialytic hypotension. But most important is the decrease in plasma volume resulting from high ultrafiltration when the compensatory responsive are inadequate, and these compensatory responses are the cardiovascular responses, neurohumoral responses, and the plasma refill. Blood pressure, as you know, is the function of cardiac output and peripheral vascular resistance, and the cardiac output is again the function of the stroke volume and the heart rate. When there is decrease in plasma volume, there is decreased venous return, and this decreased blood volume here in the right atrium and the pulmonary artery is sensed by the baroreceptors there. And if there is more severe loss, then this volume is also sensed by the receptors present in the arch, aortic arch, and
He
the carotid
received his
arteries
medical
here.
degree from King
And
Edward and
they become
has been practicing nephrology for
deactivated.
11,
That result
15
in
years.
release of tonic inhibition
Dr.
of the
Umar, please.
sympathetic outflow, resulting in
Thank you.
stimulation of the vasomotor center, more sympathetic flow, and resulting in increased plasma norepinephrine, activation of the renal angiotensin aldosterone system,
in
increased
1969,
secretion of the
Gordon and
vasopressin,
Maxwell,
and
so
then
they
the secretion of the adrenaline.
kind of
All these
gave this
vasopressor
idea of
hormones
portable
lead to
dialysis.
vasoconstriction,
Flow at 42,
increasing
dialysis
the
at
peripheral
43.
resistance.
There was urea
The
clearance,
constriction
creatinine
of
clearance,
these
16,
resistant
17,
vessels also
phosphorus and
pushes the
beta-2.
blood present in the capacitance vessel and resulting in the improvement in the venous return and cardiac filling. And that cardiac filling is also facilitated by the improvement of the central blood volume due to the redistribution of the regional circulations and also due to the transcreptory fluid shift. All these things lead to plasma refill, increase the venous return, and increase diastolic end volume by the Frank-Starling mechanism increases the force of contraction, resulting in the stroke volume, and that results in the cardiac output. And this is also facilitated by these hormones, which have inotropic and chronotropic effect, leading to increase in force of contraction and the increased cardiac rate. So the cardiac output will be increased, peripheral resistance will be increased, blood pressure will improve. If these compensatory mechanisms do not work or are inadequate to balance the loss of plasma volume, the patient will develop hypotension. Now, this is normally when there is increased blood flow through the resistance vessels, these capacitance vessels, they stretch and there is pooling of the blood in those capillaries, leading to compromised venous return here. And when there is increased resistance or constriction of these resistant vessels and blood flow decreases, then this elastic recoil of the capillary wall pushes its blood downstreams, leading to increase in venous return. And this is known as de Jaeger-Krog phenomena. The redistribution of the regional circulations. Four regional circulations are important in that sense. So plankning is the most important, and then the cutaneous circulations, and in more severe volume depletion, kidney and muscle circulations also take part. All this blood contained in this venous circulation, because of the V1 vasoreceptors in here and increase in vasopressin, constriction of the splanchnic vasculature, pushing the blood back to the heart. More central circulation, increasing the venous return. Transcapillary shift, when there is loss of volume, decrease in hydrostatic pressure in the capillaries, that facilitates the shift of interstitial fluid into the vascular space and increasing the plasma volume. One more important phenomena here, the basal-gyrus reflex. When there is increased sympathetic activity, vigorous contraction of the left ventricle here and rapid rate there leads to stimulation of the mechanoreceptors present in the left ventricle, and those activation of those mechanoreceptors reflexly inhibit the vasomotor center and also stimulate the parasympathetic activity. That leads to decreased sympathetic activity, increased parasympathetic activity, peripheral vasodilatation that will lead to decreased peripheral resistance, and also because of increased parasympathetic activity, bradycardia. This is sort of a protective phenomena. By causing the bradycardia, the heart will have more time for the filling and may improve the stroke volume. And this phenomenon is important to be recognized because some of these medicines, the vasodepressant medicine like clonidine, diltiazem, or propranolol, which are otherwise contraindicated or not advised during hypertension, may be helpful in this situation by causing bradycardia, allowing more cardiac filling, and improving the stroke volume. Treatment usual, number position, reduce the ultrafiltration rate or stop ultrafiltration, infuse boluses of 100 ml normal saline, infusion of salt-poor human albumin, although it has been shown that no advantage over the saline and more costly, and then the hypertonic solutions, 20% exo, saline 2.5 molar to 10%, or mannitol 2.5%. If you are using those hypertonic solutions, it is important that these solutions must be administered more rapidly. This is the study done by Simous, who shows that when this 2.5 molar saline 20 ml was administered in 2 minutes, this was the effect on the serum osmolarity. This was the plasma vasopressin increase, plasma volume, and the impact on the blood pressure. As compared to when the same amount of 2.5 molar solution saline was given over 5 minutes, the increase in serum osmolarity was much less as compared to here rapid infusion. Similarly, the increase in arginine vasopressin was less here, and this, the effect on the plasma volume and the effect on blood pressure was less. So if you are using those hypertonic solutions to prevent this hypotension, then it must be infused more rapidly. There's no need to reduce the blood flow. This is often practiced that when there is hypotension, in addition to stopping the ultrafiltration or slowing down the ultrafiltration, blood flow is reduced also. There's no need to do that. And during hypertension, obviously, oxygen may be required to maintain the end organ function, or direct acting alpha-adrenergic agents could be used, norepinephrine, epinephrine, or indirectly acting sympathomimetic drugs like amazonium, or finally, if the blood pressure does not improve, you might have to stop the dialysis. While you are taking care of that acute episode, then you must be looking for some other more serious causes like sepsis, hemolysis, pericardial effusion, worsening of the cardiac infarction, just MI or chest pain, bleeding, melena, hematemesis, hematochezia, air embolism, dialyzer reaction, or medicine overdose. Those can also lead to hypotension. You must look for those also. And what do you do to improve or prevent these? First thing is, as I mentioned, the most important factor is the ultrafiltration rate leading to hypovolemia here. To reduce the ultrafiltration rate, increase peripheral resistance, optimize cardiac output, and improve the plasma refill. To decrease the ultrafiltration rate, higher ultrafiltration rate is when there is more intradialytic weight gain. If you could control the intradialytic weight gain, then you should be able to decrease the ultrafiltration rate. And to limit the intradialytic weight gain, most important is the dietary counseling. Sodium-restricted motivational induced may be needed, sodium-restricted diet, avoid hypertonic dialysis, reassessment of the diabetes. Erroneous assessment of the diet may lead to increased ultrafiltration rate. Most of our patients are diabetics, so control of diabetes, control of blood sugar is very important. Then maximize diuretic use if the patient has residual kidney function. That will help to reduce the intradialytic weight gain and help to reduce the ultrafiltration rate. Increase the frequency or increase the duration of dialysis if the costs and the resources allow you. For the assessment of dry weight, in addition to the clinical examination, many of those other helpful maneuvers, the gadgets may be helpful. Blood volume monitoring, ultrasound assessment of the inferior vena cava, then measurement of these VNP and terminal VNP, atrial peptide levels, ultrasound of the lung for the water indices, and then biovenous methods. Use of diuretics, as shown by Siebel, two groups were compared, the one who have fulfilled their prescriptions of loop diuretics and the other one who did not. So they showed that those who have fulfilled the prescriptions of loop diuretics, they have lower intradialytic weight gain and lower incidence of intradialytic hypotension. Optimize ultrafiltration. So during ultrafiltration, make sure that the patient does not develop severe hypovolemia, which leads to hypotension. Different maneuvers has been tried, the ultrafiltration profiling, sodium profiling, combined ultrafiltration sodium, hypertonic, hypernatremic dialysis, isolated ultrafiltration or sequential dialysis, blood volume monitoring, biofeedback technologies, and then hemodialysis or hemodiafiltration or hemofiltration. Different types of UF profiling. This is the linear, higher ultrafiltration at the beginning, and gradually it is decreased here, stepwise decrease, intermittent, different patterns, different periods of ultrafiltration and no ultrafiltration. And this was shown in that the linear pattern has the least incidence of hypertension and less symptoms as compared to intermittent or step-down patterns. Then this song, he compared these 8 different protocols. Control, no sodium profiling, no ultrafiltration profiling. Then step-down sodium profiling only, where the mean sodium was kept about 143 milliequivalent. Then step-down, where the mean sodium was kept 138 milliequivalent, and intermittent profiling, sodium profiling only. Here, ultrafiltration only, then combined sodium profiling and ultrafiltration with the higher mean dialysate sodium, then combined sodium and ultrafiltration profiling with the normal sodium level, 138 milliequivalent, and then combined sodium and ultrafiltration intermittent profiling here. And they showed this combined sodium and ultrafiltration profiling, they are better in causing the or improving the hypertension incidence here as compared to sodium alone or ultrafiltration alone. So we also showed the same thing, that sodium and UF profiling combined, you have lower incidence of hypotension as compared to UF alone or sodium alone. In this study, SANS showed that combined sodium and UF profiling, the blood pressure was maintained at a higher level as compared to sodium or ultrafiltration alone or the controls. High dialysate sodium. Higher dialysate sodium leading to higher plasma osmolarity, and that mobilizes the intracellular fluid into the extracellular space and allow removal of fluid from both IC and extracellular fluid, fewer episodes of IDH, better dialysis compliance. But that also results in higher plasma osmolarity, increased thirst, increased intradialytic weight gain, and hypertension. So this is recommended that you should not use this higher dialysate sodium dialysis. Isolated ultrafiltration with removal of isoosmotic water, there is increase in oncotic pressure in the blood. That results in the movement of water from the intracellular compartment to the extracellular compartment, so helps to decrease the incidence of hypotension. So you can use it isolated ultrafiltration or sequential dialysis, that ultrafiltration with no dialysis followed by dialysis with no ultrafiltration. Biofed feedback systems, blood volume tracking system, blood pressure control system, blood temperature control system, but these are limitations that still require an input regarding the ultrafiltration volume, the relative blood volume limit, or the desired target volume reduction when they have human error again. The blood volume feedback by the Fresenius company here, real-time monitoring of blood volume here by the use of ultrasonic probe, which measures the hematocrit and protein level, and there is a desired blood volume which is set up in the machine, and then this is controller which tries to keep the blood volume controlled close to the desired blood volume by adjusting the dialysis conductivity or the ultrafiltration rate. This is a hemocontrol system. They have a measurement of the actual UF, actual sodium, actual blood volume, and then the target ultrafiltration or target sodium or target blood volume are set up in the machine, and then there is a real-time modification of the setting UF rate or dialysate sodium is changed by the machine itself, keeping the ultrafiltration volume or rate close to the target. This is the fuzzy logic feedback system. And this machine in itself, instead of that target blood volume or blood pressure being set up by the operator, the machine itself devises a ideal or desired volume curve here, and then monitoring the ultrafiltration rate and actual BVM, adjust the conductivity and ultrafiltration rate to keep the relative blood volume change close to the ideal. Limitations of these machines, one is the costly, secondly, blood volume monitoring assumes that the red cell mass or plasma protein density remains constant throughout the length of the session, which may not be true if there is hemolysis or blood leak. Hypotension may not be predicted when the blood pressure decreases due to decrease in cardiac output or decrease in peripheral vascular resistance. Okay? And then there is a need for feeding the setting up the critical relative blood volume change by the operator. There's the steps to improve the peripheral vascular resistance. You need to avoid meals immediately or before dialysis. Use the bicarbonate dialysis. Dosing and timing of the antihypertensive medication. It is important that you don't give the medicines before the start of the dialysis. Dialysate composition, dialysate calcium more than 2.25, magnesium more than 1, and pool dialysis is the important one. Here is the effect of meals on this splanchnic circulation, normally about 30 ml per 100 grams per 100 grams of the tissue, and after meals it goes up to 250 ml per 100 grams. So that's why all those splanchnic circulation that will have more blood there instead of being returned to the blood. So you need to avoid the meals during dialysis, bicarbonate dialysis, fewer incidence of intradialytic hypotension as compared to acetate. Timing of the pressure medicine during dialysis. This was a recent study that showed there was no difference between the two groups who took the medicine before and the other group who did not take the group, and they recommend they should not be withheld before the dialysis. And when this study is undergoing, started in 2018, results hopefully will be out in December 2019, whether we should stop the medicine or not. Low dialysate temperature is an important maneuver. The temperature, dialysate temperature 35 to 36, two different methods, empiric fixed reduction or isothermic dialysis technique in which the whole body temperature remains constant while the use of biofeedback temperature controlled devices. And there are two large meta-analysis. One was in 2006 and the other one was 2016, comprising 22 and 28 studies, all showed that it is favorable, that it helps to reduce the intradialytic hypotension. Pharmacological preventions, midodrine has been used, L-carnitine, sertraline, caffeine, intranasal DDVP, doxidopa, and until recently the impact of midodrine on outcome in patients with intradialytic hypotension, and they showed there was a more ischemic injury here, more hospitalization, more cardiovascular hospitalization when the midodrine was used. So that has to be used very carefully. So dialysis-related hypertension is a common problem, occurs due to the imbalance between ultrafiltration rate and cardiovascular neurohumoral compensatory responses are inadequate, and plasma refilling is inadequate. There can be significant interpatient variability in response to using the same treatment approach. This is important. Just like one size does not fit all, a personalized approach is needed for every patient. You can't use the same treatment for everyone. More attention to be focused on reducing the ultrafiltration rate by controlling the intradialytic weight gain by sodium restriction, avoiding meals during dialysis or just before dialysis, using low dialysate temperature, and then using sodium and ultrafiltration profiling. The technology has much to offer, but has not solved the persistent problem. Then the team care. Nurse for close monitoring in high-risk patients, pharmacists to review the timing and dosing of the antihypertensive medication, adherence to the drug therapy and monitor the drug-related side effects, dietitian for the sodium restriction diet and fluid restriction, and the specialist, obviously, the nephrologist for the correct assessment of the dye weight, and the cardiologist for optimizing of the cardiac function, especially if the patient has ischemic heart disease, heart failure, cardiac arrhythmias, or pericardial effusion. And thank you.
Thanks very much, Professor Tashafi, for such a comprehensive talk. We'll proceed to the last speaker of the session.
Well, the next speaker is Dr. Peter Hill, who is a consultant nephrologist.
Good afternoon. Thank you very much for holding on for the end of this session. I've got a big topic to get through today, and I don't think I'm going to complete all of it. But what I am going to try to communicate today, where I think that sort of some of the interesting interventional research has come through. What I'm quite taken about by being in nephrology, so really since 1997, when I was a lowly senior house officer for Professor Brown at Charing Cross, was just how sick our patients are. And I was quite taken really with just how life expectancy really is very variable, with many patients who started dialysis a number of years ago, particularly those that were doing home dialysis at Charing Cross, were surviving extremely long. But the life expectancy was equally rather short for others. In the United Kingdom, with our data registry that every renal unit submits data to, I was looking back at a report a few years ago and noticed that if you were my age, which I've turned 50 in May next year, and I was diabetic, my life expectancy on hemodialysis, if I was diabetic, would be about 5 years. And I spend quite a lot of my time working at the Royal Marsden Hospital, which is a cancer hospital, looking after patients who get complications of cancer therapy. And I tell you, kidney cancer has a longer prognosis compared to what we're achieving on dialysis. We've seen this slide in most lectures and in most meetings. You'll see this slide from Rob Foley that came out in 1998. If you're a medical student completing their final year at age 25 and they happen to be on dialysis, they have a cardiovascular outcome that's similar to someone in the general population in their 80s. And I don't think we've really impacted on this outcome significantly since Rob put these slides together. Because chronic kidney disease is associated with very accelerated cardiovascular disease. Now that is really grim for the patients most importantly, but on a population, if we're dialyzing patients who are going to live for a short period of time with an expensive therapy like dialysis, that's going to have considerable healthcare implications to a budget, particularly in the developing world, and importantly within families themselves. So what are our patients dying from? Well, it's cardiovascular complications. This bar chart here, looking at US registry data, tells you that sepsis is significant, and I think that's predominantly from Staph aureus and other catheter-related sepsis that's increased in our patient population. But our association of cardiac disease is really over 50%. Now, they're not dying of acute myocardial infarction. They're typically dying of sudden cardiac death, and that's largely related to the cardiac uremic cardiomyopathy that the dialysis or the chronic kidney disease patient is exposed to. The toxicity of the uremic environment causes fibrosis. They tend to have problems with electrolyte disturbances, volume fluctuations that we've just heard about in that last eloquent lecture, and then similarly with problems with hypertension and left ventricular hypertrophy, and then other problems. So largely patients are set up for an ischemic or at least a cardiomyopathic event. So why does this happen? Well, let's look at this wheel of really everything that's causing cardiovascular disease. First of all, our patients are primed. They tend to be hypertensive. They tend to be diabetic, and a lot of them don't do very much. Then the dialysis environment itself with the uremic toxins is important. Homocysteine is elevated as part of the end-stage program. Salt and water overload is predominant, and then there are other aspects like inflammation that are and wasting from malnutrition are equally becoming increasingly important. So let's think about what we can do in these circumstances, and I'm going to focus on some of these traditional risk factors, and then talk about some of the uremic risk factors in addition. So let's go on to the traditional risk factors. We know that it makes biological sense to correct all of these as best we can. Now, smoking cessation is really important. There's data to support that. Good glycemic control in pre-dialysis, particularly in type 1, has been shown to be beneficial, and preventing problems with ischemic heart disease and good blood pressure control are important, particularly in chronic kidney disease. But in dyslipidemia, where we do have an intervention with potential toxicity with statins, the data in pre-dialysis is not bad, with Colin Bajent's work and in CKD, showing early intervention with ezetimibe and simvastatin. In the SHARP study, showed a reduction in interventional rates in ischemic heart disease. Not an outcome data benefit, but at least some improvement. But in the dialysis population, large studies have not been positive. The German study, the 4D study, used atorvastatin in new diabetics starting dialysis, no outcome benefit. Aurora used atorvastatin in a very large study, and again, no clear benefit. So what we're doing in cardiovascular disease in terms of sort of traditional risk factors is I think we're seeing patients too late. Once they start dialysis, the pathology has already damaged them, and perhaps aggressive use of statins is not mandated. And if there's side effects of statins, I think they could potentially be not be administered, although I think it does make biological sense, and I use statins in my standard practice. So where we have put in evidence is before they meet the dialysis machine, and that's where I think we should be putting our efforts in terms of preventing cardiovascular risk. Now, unfortunately, in the United Kingdom and I think in Pakistan, most of our patients meet us sort of a bit too late. Now, if they meet us early, they're going to live much longer. There's nice outcome data to support the role of the nephrologist, but in terms of what we can do once they reach the machine, I think it's rather difficult. It's not as clear cut. So what can we do? Well, first of all, let's look about what we can do with dialysis technology. So there are two things that I think of. There's one thing I'm going to start with. One is biocompatibility. And there are two studies, the HEMO study and the membrane permeability study. Both showed that if you use high flux dialyzer, you might get slightly better. It makes biological sense in the HEMO study that by reducing beta-2 microglobulin, that you will get better clearance of smaller molecules and middle molecules that will then give outcome benefits. And there was in the HEMO study a lower risk of death from cardiac diseases in secondary endpoints. But the total mortality was the same in the length of that study. In the membrane permeability study, a trend towards survival benefit, but not enough to say actually high flux is what you've got to do. What about time on dialysis? Now, I don't know of a single dialysis patient that loves dialysis. And in the model that's run here and the expense of dialysis, it's very difficult to convince patients to do a long time on dialysis, in particular frequency, where I think most patients that I've been hearing in my visits, both on this occasion and last year, are doing twice a week hemodialysis. Now, the DOPS data, and also from the registry in New Zealand, showed that if you do 4 hours of dialysis, you get some benefit. And we've known that for some time when we look at the data from France, from the Tassin unit that does long, slow dialysis, that there's an increased survival with their treatment. And in fact, if you lived in Lyon, I'm sure you could tolerate the 5 or 6 hours of dialysis that they prescribe, you would probably choose to dialyze there if you didn't have access to transplantation. So I think there's good evidence that a good amount of time on dialysis is a good thing. Now, our kidneys are working all day, every day, so it makes biological sense again, doesn't it, to give as much time as you can possibly afford. What else should you do? Well, I started my career with Professor Brown, and so I've been sort of indoctrinated into the benefits of peritoneal dialysis. And what peritoneal dialysis doctors are always doing is they're always trying to preserve residual renal function. And what that means is that you can, as we've heard from the previous talk, about how that limits, how that prevents the intradialytic hypotensive episodes, and as a result, the myocardial stunning and the other issues that you develop if you have large intradialytic weight gains. So maintaining normal physiological fluids as much as possible, probably by preserving as much residual function, is important. And we've heard it from throughout this conference and for others how fistula first is beneficial and keeping away from cuff catheters. And some people in the audience will think that's rich from somebody coming from Imperial. Now, what else can we do? Well, we know that if you've got chronic glomerular disease or polycystic kidney disease, you do better. So we need to be making it, but these people are young, so that's probably why they do better. We also say that in Europe and Japan, we're a bit better at keeping dialysis patients alive historically compared to the United States. And nutrition, we need to really be looking with our multidisciplinary team to be concentrating on preventing undernourishment. We ought to be looking at salt intake. Again, the HEMO study suggested that limiting salt was important, and if you're inflamed, you tend to do badly as well. So all those things on that big wheel are all coming together. And this is where I think we are lacking both across the developed and developing world, is how patients don't meet us until it's too late. If you have a planned start on dialysis, which is within this large group here, you'll be seeing that you have an improvement in your outcomes compared to those unplanned starts. And that's about offering good, comprehensive CKD management. Now, if you're in a healthcare economy where the primary care physician is taking the income for looking after patients with chronic kidney disease, and they're doing a good job, well, that's great. But if they're not doing a good job, we really need to be working out how to educate that group if they're not going to refer them to us, because we're better at it. We can put them into a team. We can put we can start looking at all of those risk factors early, and I think we can impact that. But in many centres, and the UK is no different, in that in early referral isn't happening, and in fact in some cases, even if they are under nephrology, they're starting on a cuff catheter far too frequently. There are other issues about frailty and behaviour. If you have a motivated person who's in the centre of their clinical decision making, they're likely to do better, and there's some data to support that. But if you're frail, had fractures, or you're non-compliant, you do worse. I don't think I'm stating anything in this run through of risk factors that's not bleeding obvious, really. So let's think about where we can make some intervention, because all of that really makes sense. We do as much dialysis as we can afford to do. We maintain good physiological fluid balance, and we maintain hypertension, and we use a fistula if we're on dialysis. But what can we do on our monthly bloods to maintain things? Well, we should be looking at some of these, I think, and there is some intervention data in particular looking at some of these aspects with hyperparathyroidism and vascular calcification. And the metabolic bone disease or mineral bone disease parameters of these are increasingly, I think, ones where there is some intervention data. So let's go through this in some diseases. We lose nephron mass, you retain phosphate as a result of loss of tubular function. You also result in loss of vitamin D, so serum calcium is maintained by hyperparathyroidism, and that releases serum phosphate. So you'd think that serum phosphate would start to go up quite early in kidney disease, but it doesn't. It goes up quite late, really as you're approaching the dialysis program. And that's because of the protective factor and the phosphotonin chemical FGF23, and how this promotes tubular excretion of phosphate using the cofactor clotho. So we have our phosphate-rich meal, a load of meat, a bit of cheese, milk, or whatever. We take that up into our gut, and our bone releases FGF23, tells our kidney to pee out extra phosphate, and it inhibits hydroxylation of vitamin D, so you don't get gut uptake of calcium and phosphate. A nice biological process. And it's happening early in renal disease, really, I think, reflecting the fact that phosphate is a bad chemical. And it's toxic. It changes the vascular smooth muscle cell to a beautiful bone-generating, osteoclastic-looking cell by what it does by changing by exchanging gene production of vascular smooth muscle cells, loading calcium phosphate and promoting fibrosis with collagen. And if you are exposed to high phosphate or high calcium, you get a great deal of calcium deposition in vessel walls. Let me talk you through this slide a little bit. If you take a vascular cell from a patient from somebody who has been transplanted, and you put them into a bath of either high phosphate or high calcium, and you then look at what happens to the vascular smooth muscle cells in the vessel wall, as you expose them to high phosphate or high calcium, you get a much greater deposition of calcium and phosphate. So this is sort of reflecting this change in phenotype. You've got a beautiful stretchy vascular smooth muscle cell around your blood vessel. We expose you to high phosphate or high calcium, and you turn it into a calcium depositing chemical, and you get this circumferential medial calcification, but not just because of mineral bone disease, but also because of the uremic environment. And I think this is why in that one of those first slides we're not seeing acute MIs. These are rigid tubes. If you drop flow along that rigid tube, you get ischemic at the end of the organ that's at the end of that blood vessel, and I think this is promoting myocardial ischemia and potentially sudden death. So we know that in mineral bone disease that as it becomes more poorly controlled, your risk of death is increased. So poor phosphate control, hypercalcemia, and abnormal parathyroid and hyperparathyroidism all result in an increased risk of death from large registry studies. And if you lower the phosphate, if you lower the phosphate and your phosphate's lower, you do better. So lowering the phosphate with decent phosphate binders is important, but what we don't want to do is to expose patients to too much calcium. And we've done that historically through the use of our calcitropic agents such as alpha-calcidol and calcium. So let's look at calcium turnover. We take about 1 gram of calcium in our diet, a load of it's put into our bones, and we excrete about the same amount, with a little coming out through the kidney, which we lose in end-stage renal failure. But what we also do in end-stage renal failure is, in order to give us good dialysis and stable dialysis with no intradialytic hypotension, we may put a dialyzer, we may put a dialysis tank of 2.5 on in order to give us prevent hypotensive episodes. But we load the patient with calcium as a result. We might use a ton of calcitriol or alpha-calcidol to normalize the PTH, so we get a bit more than 1 gram of calcium being taken up, and we give a bit of extra calcium carbonate because they're damn good binders and they're cheap. So with this, I think we've got patients who are hyperphosphatemic, and then we're loading them with phosphate in addition. Now, if we get our PTH just wrong, like Goldilocks and her porridge, if you don't get the PTH just right, you get vascular calcification. So hyperparathyroidism leads to efflux of calcium and phosphate. that goes into tissue and vascular calcification. If you're hypotensive, you've the calcium phosphate can't, sorry, hypoparathyroid, your phosphate and calcium can't get into the bones, so you end up with vascular calcification. And that's why I think sort of with getting it just right and not targeting an actual value has been really helpful with the new KDIGO guidelines. And if we don't get it right, rather than dying from an atheromatous plaque, this rigid tube causes end organ ischemia, such as calciphylaxis, which in these extreme conditions is largely pre-morbid. So how should we do it? We need to really just get any binder into you no matter what. I think getting the phosphorus down is extremely important in the dialysis population. Now you'd think that using the calcium-free would be beneficial, but in the large studies, such as DOCOR and then another observational study, RIND, there was no primary endpoint unless you were over 65. So despite the potential biological benefits of calcium-free, there hasn't been clear outcome data in RCTs. When you look at this in meta-analysis, there is some benefit. So perhaps we ought to be looking at calcium-free if patients can afford it and can tolerate the agents. And that's been reflected in what KDIGO has put in terms of the management of hyperphosphatemia. And you can see here that the KDIGO said avoid hypercalcemia and monitor your CKD parameters as every 3 months for our dialysis, monthly for dialysis patients, and try to minimize calcium exposure. Sorry, my slides got out of order for some reason. Yeah, try to minimize calcium exposure. So I hope during that sort of very quick run through of cardiovascular outcomes, I think we need to be sensible with our approach to dialysis. I think we need to make sure that we're providing as much dialysis as a patient can afford and tolerate in order to give them as much clearance. And I think 4 to 5 hours is where I would prefer to go. I'd try to maintain residual renal function, and I'd very much promote the use of an AV graft. I'd minimize ultrafiltration, and I don't want blood pressure over-controlled. It needs to be about just right. And the controversy with blood pressure I purposefully did not include because I think that's quite controversial. And what I have done is talked about avoiding hypercalcemia and normalizing phosphate, and I think we should be maintaining hemoglobin. Now, I think this is fine many of these interventions are fine in the developed world where dialysis time and length of dialysis is funded. But I think we should also be sort of concentrating on thinking that the outcomes of dialysis are poor, and access to transplantation and how to improve transplantation is something that we need to be putting a lot of effort in patients who are likely to have very poor outcomes unless they can afford and very expensive treatments such as hemodialysis. So I'll end with a picture of...
We have a little time for 1 or 2 questions. Please go ahead.
Thank you, Peter. Excellent talk. I think one of the most important, just a comment really, I think one of the most important things which is coming up is a good pre-dialysis care can be an important factor in terms of mortality when patient starts renal replacement therapy. So I think we need to invest more and more in developing that side of things in addition to all the other things which you've mentioned.
I completely agree. By the time they're on dialysis, the circulation's damaged, and I think getting that back in a completely non-physiological situation is impossible for us to make an impact on outcomes. The title of the request was to talk about outcomes in hemodialysis, but I think you're absolutely right. The effort has to be in pre-dialysis care, and we're unfortunately not the people that meet those people in a timely manner, sadly. And I think communicating this and getting our message out about how rubbish dialysis is in terms of outcomes needs to be communicated into the at-risk groups in endocrinology and into hypertension. And in Britain, for some reason, the hypertension clinics run by the cardiologists, and the diabetic doctors, they're very good at noticing albumin-creatinine ratios, but they don't then refer them on until it's quite late, sadly.
Well, thanks very much, Dr. Hill.
Sir, I have a question, sir, please. Sir, I have a patient with 4,000 PTH. What is the indication to give calcitonin for how many months, then go for parathyroidectomy?
Sorry, I couldn't hear, the acoustics aren't that good, there's lots of echo.
I have a patient with 4,000 PTH level.
Yeah.
We have started vitamin D and all other things. What is the indication to give calcitonin for how many months? Then go for parathyroidectomy.
So a high parathyroid, and you'd like to know about using cinacalcet, is that correct?
For parathyroidectomy if tertiary hyperparathyroidism.
May I request you to please have a chat with Dr. Peter later on?
I think we're short of time. You can ask questions later.
Sure.
During the...
Thank you.
Just a few comments before we distribute the shields. We talk about the patient-centeredness Dr. Qadri presented it. I think we, the physicians, have been looking after the patients from our own perspectives, and we talk about the investigations, the values, and things like that. For the patients, the things are different. They talk about the quality of life, the psychosocial impact, and the nutritional status, the physical health, and these are the matters what we physicians do not routinely focus on, and that's why the newer concept of value-based healthcare is there, and the whole Harvard group, and they are working on the value in healthcare, and that is based on the outcomes that matters to patients versus the cost incurred to deliver those outcomes. And regarding ESRD, I think the society or the Pakistan Society of Nephrology need to think on that way. We need to really develop a ESRD program. Not every patient would be dialyzed, not every patient can be transplanted. And there is an incidence of 100 per million population. That means we are looking at 22,000 patients, new patients per year. We don't have the capacity to cater to all these. And regarding the dialysis, hemodialysis is really a resource-intensive thing, intensive procedure, and resource cost is not the only resource. We can imagine the water consumption that is required for each patient. If we think of the waste and plus the RO water, 220 liters straight away for a single session. So we can imagine what can be the problems if we even program to dialyze all those patients. So there is a need for the society, I think, to look on a holistic way to the end-stage renal disease program. What should be the criteria, who should be dialyzed, who should be given peritoneal dialysis. We have not worked, and Dr. Frederick this morning talked about that, and we need to really focus on the peritoneal dialysis. We need to develop that entity. So that's my comments. And
so after the shield distribution, just to remind you, there's a very important brief session after this on pediatric nephrology.
So before we move on to the next session, I would request Dr. Ijaz and Dr. Bilal to please confer shields to their speakers. Our first speaker was Professor Mustafa Qadri. Can you please come forward and receive your shield, please? Dr. Umar Farooq, please come forward. Professor Mary Richards, please come forward and receive your shield. Respected sir, Professor Tahir Shafi, please. And Dr. Peter Hill. Again, I would like to thank you all. And
sir, there are shields for chair and co-chair as well. We will request Professor Tahir Shafi Saab to kindly spare a minute for distribution of shield to our chair. Professor Hafiz Ijaz Saab. Dr. Ashar Alam Saab and Dr. Bilal Jamil. Thank you, sir. Well, there is a little announcement. There was another session of pediatric nephrology that was supposed to occur in this hall, but now it has been moved on to the next hall, that is Hall B. That would occur immediately after this session. Thank you.